If everyone wants to drop into the chat where they're tuning in from, we'd love to hear from you. All right. Okay, hi Beverly from Orlando, Atlanta, Georgia, Voorhees, New Jersey. I've been there. Oh, Judy from Maryland. I grew up in Silver Spring, Maryland, so always good to see fellow Marylanders. Well, we will be getting started at the top of the hour, but I did want to greet you and let you know a couple of the housekeeping items. So the chat function that you're using is going to be your communication line. That's how you can send us questions. You can either send them to everyone or you can send them to me privately. And then our host moderator will relay those to our expert. So I think Thomas was asking, so everyone is on auto mute. We have a large crowd today, so we want to make sure that we can deliver this content. Oh, thank you, Carol, for the thumbs up. And then the best way for you to ask questions and have that lifeline is through the chat. I will mention that on NeuroLife Online, we have a full spectrum of programs. Some are built around, socializations. We actually have peer discussion groups. So if Thomas, you were looking to, you were hoping to be able to, speak on camera and interact more, I'd recommend everyone take a look at our website for the full listing of all of the many programs that we have. In the month of July, we have pretty much something every day. And let's see, the best way, if one of my helpers could drop in the chat that summary, then you'll be able to peruse through and see maybe what suits your fancy and what you'd like to register for. All right, well, I do see Dr. Subramanian has joined and Dr. Rucker as well. Welcome, everyone. So again, thank you for joining us. My name is Andrea from PMD Alliance. We're the nonprofit hosting today's program. And with that, I'll turn it over to our facilitator, movement disorder neurologist, Dr. Indu Subramanian.
Thank you. Welcome, everyone. Hope everyone's doing well out there in our virtually connected and socially, unfortunately, distanced universe here. I guess we're physically distanced. Hopefully we can socially connect. So pleasure to continue to host these and bring you cool content of friends and colleagues of mine around the world. And this is a really interesting and important topic today, brought to you by a good friend of mine, and a really good example of how the Movement Disorder Society and the meetings that we have, and we're going to be having a special event for World Brain Day next Wednesday with Claudia Trenkwalder, who's our president of the Movement Disorder Society, who's going to be teaching us a little bit about why the MDS, as we fondly call it, is important, and it links so many of us globally and internationally, and really is just such an amazing place to network and find new friends. And so I had the pleasure of seeing Janet talk. I was in the audience in one of her eye movement lectures and was just floored by how clear she made things and her videos and her way of expressing things, and just really impressed with how smart she was. So I was like, I have to meet this person. So I went up to her afterwards and I congratulated her on her excellent talk. And then we became close friends, actually. So I'm happy to say that we've evolved just from colleagues to friends, and we travel to places together. We were just in Nice and stayed together in a beautiful place in Old Nice. And really, it's just been such a lovely thing to get to know Janet and all of her interests outside of medicine, but also really continue to be in her fan club of, just in awe of her intelligence from many perspectives. So she is a professor of neurology at the Department of Neurology at the NYU Grossman School of Medicine. And she's also a professor of ophthalmology there. So she's dual appointed there, which is already really brilliant. She runs the Neuro-ophthalmology Fellowship Program. And she really just bridges the gap between, I think, ophthalmology as a neurologist. So she's my go-to person when I have questions about anything from a vision perspective for our patients, not just with regular Parkinson's disease, but many of you know that we take care of the Parkinson's plus disorders too, some of which have more issues with eye movements. And so today we're really going to be focusing more on the regular Parkinson's disease. Dr. Litvan is an upcoming speaker who will be talking about the atypical Parkinson's syndromes as well in the next couple of weeks. So we have some really just fabulous speakers. So it brings me great pleasure to introduce Janet Rucker to you all. Dr. Rucker, welcome. Maybe you could tell us a little bit about your journey to, first of all, your interest in medicine and then in neurology, and then this sort of borderland between neurology and ophthalmology, and why you like working with our Parkinson's patients.
Sure. So Dr. Subramanian is always too kind, but it is a great pleasure for me to be with you today. I really do have passion for movement disorders and Parkinson's disease, and I see a lot of patients in my clinic, at least 1 or 2 patients with Parkinson's disease or atypical Parkinsonism each time I'm in clinic. I have a tight relationship with a lot of the movement disorders doctors in New York too. So I really decided to become a doctor when I was in high school, but I don't know why. I didn't know what it meant really. No one in my family had gone to college, and I just set my sights on that was what I was going to do. And from there forward, through medical school and to the present, I really think that this is true for a lot of doctors, that the path that we end up following and what we end up doing is really driven by the people we meet along the way. And we get inspired, we fall in love with a content area, but we really get inspired by the doctors that we work with. So neurology was a natural fit for me. It was always neurology from the very beginning of medical school for me. And neuro-ophthalmology was not what I thought I'd end up doing. Most people haven't even heard of it as a subspecialty. But ultimately, again, I had the opportunity during my training to be very exposed to world famous neuro-ophthalmologist Nancy Newman. And I just spent time in her clinic, fell in love with it, and wanted to train with her and ended up doing so. And then after that, my first job was with one of the world's experts in eye movements. And so I had the good fortune of getting additional training in eye movements, and never work a day in my life because it's always a pleasure what I do, and I enjoy working with patients.
That's amazing. So you went from a family with no one even going to college to becoming this, world expert in this really important field. So lovely. So teach us a little bit, Janet. I know you put some slides together about eye vision issues in Parkinson's patients. Maybe we'll go through those first, and we can take some questions, as we go after you complete the slides, and we'll evolve a discussion. I know you've been very active in publishing even on how to continue to see patients in the COVID era, because it has put a real barrier in our ability to be able to interact with our patients. And I know that a lot of the testing that you do, one would think requires somebody to come into the office. So maybe you can teach us a little bit after, if it's not already in your slides. I'd love to hear about how you're facing that challenge.
Absolutely. Yeah, that's not actually in my slides. And I think that's really a critically important thing to discuss. So we can certainly talk about that at the end. I'll go ahead and share my slides. All right, so as Indu said, we're going to really focus on Parkinson's disease in general today rather than the atypical Parkinsonisms. And there's a big scope to this problem, as many of you or family members or patients, individuals with Parkinson's are with us today. I'm sure some of you have some of these symptoms and appreciate that this is a big issue for patients with Parkinson's disease. In the medical literature, it is shown that 78% of patients with Parkinson's disease report at least one visual symptom. Now, the visual symptom may or may not be related to Parkinson's disease, but there are some that are fairly specific. There might be complaints of blurred vision, which is fairly non-specific. Could be difficulty reading or double vision with reading or at distance. Light sensitivity issues are common. And then some what we call more higher cognitive or higher cortical types of issues. One would be misjudging objects and distances. So trying to set something on a counter and misjudging where the edge of the counter is, or trying to go through a door and misjudging where the door frame is. And then finally, another common one, of course, is visual illusions and hallucinations. So an illusion is a misperception of something that really is present. The simplest example might be looking at a straight line and it appears as if it's bent. And then hallucinations are perceiving things that actually are physically not present. So a couple of types of hallucinations and illusions that can occur are called illusions of presence or passage. These are not necessarily purely visual, but illusions of presence might be sensing or feeling or seeing someone in the room that's not really there. And illusions of passage would be abnormalities of kind of motion vision, detecting something moving in your peripheral vision when there's really nothing in motion there. And then visual hallucinations, of course, can also be quite complex. In Parkinson's disease, hallucinations of children or small animals are also quite common. So here's a roadmap of where we're going to go through the slide discussion today, and then we can veer off of that in the question session as well. But I'm going to give you a little bit of kind of lay person's understanding of how we see. How does the anatomy work? And then we'll spend a little bit of time talking about some abnormalities of vision that have been identified in research in patients with Parkinson's disease. There has been involvement detected at many sites along the vision and eye movement pathways. But in this category, in this part of the discussion, these abnormalities are really things that have been looked for with very fine tools. They might not be things that are readily detectable. If you see the eye doctor, for example, they've been sought after with more and more sensitive ways of looking for them. And the objective in doing that kind of work is to identify things that might be abnormal that could be followed in clinical trials to see if things improve with medication, for example. And in this part of the discussion, we're not quite sure what impact these things have on the patient's vision on a day-to-day basis. And usually, because of that, we don't really have specific treatments to recommend for them. And then lastly, and really most critically for you today, is what's common on examination, what's treatable, what can we do something about to help patients with Parkinson's with their vision. We'll end with some very simple solutions and take-home points. So how do we see? I like to make an analogy with a camera, and through the process of taking a picture and then in the olden days developing the film in a dark room and having the final product of the visual picture, our eyes, our eyeballs really are the camera. So they collect all the visual information from the world. It goes through the eyeball and lands on the back of the eyeball lining, which is the retina. It's like the camera film. And it just, all that information, light coming in, shapes coming in, lands on that retina. And then it goes back off the back of the eyeballs through the optic nerves, the vision nerves, through extensive visual pathways in the brain. And the final darkroom, the final processing stop, is the very back of the brain, specifically the vision part of the brain called the occipital lobes. So here's a kind of cross section as if we took if we cut an eyeball in half and kind of looked at it from above. You can see the cornea, which is the very front of the eye right here. This is the part of the eye we would be looking at if we're looking at a person. The iris here is what gives that eye its color, the green, blue, hazel colored eyes comes from that iris. And the lens, many of you are probably familiar with the lens of the eye, which becomes cloudy as we age, develops cataracts, and the surgeons take those lenses out and replace them with something. And then the orange part here is just a jelly in the eye. It's called the vitreous, and it gives the eyeball its shape. So when visual information comes in here, it comes all the way through the eyeball and then lands on this little sliver of orange, light orange or yellow orange here. That's the retina, that little lining around the back of the eye. And all the information from the retina then goes out through that optic nerve back to the brain. When we look in the back of the eye, we're actually seeing a piece of the brain. So here's a tool called an ophthalmoscope that we use to look in the eye. You can see a doctor here, very, very close and personal, looking in the back of this patient's eye. First, we land on the familiar view of the eye, and then we start to get a glimpse inside at that kind of orange reflections from the retina. We start to get a little more of a peek here. We keep coming closer, and then this is what comes into view for us. And we can see the optic nerve, which is that piece of the brain carrying that visual information back to the brain. We can see the blood vessels, which are all the red strands here in the eye. And then this dark spot is the macula. So some of you may be familiar with macular degeneration. That's the location where that occurs. And then the orange background underneath everything is the rest of the retina. So here's another section through the eye, similar to what we just looked at, and it zooms into this little box through the retina right here. The retina is actually quite a complex structure made up of different types of cells. So the light comes through and it falls on these little chemical factories back here called photoreceptors that process the information and then send it out through these nerve pathways back through that optic nerve to the brain. So in the big picture, we see with our eyes, but really they're the cameras. They're collecting the information. They're here in yellow, and then the light yellow here is the vision nerves coming back. And then the blue is vision pathways back in the brain. A fairly large percentage of our brain is involved with vision, actually. And so it finally lands here at the very back in the occipital lobe. But even beyond that final dark room, there's some additional processing that happens in the brain. We have these pathways that we call the what and the where pathway. And I'll tell you more about those later on. So for right now, it suffices to say that vision's a really complex process, and it's amazing that it mostly all works well and we typically can see pretty clearly. And then on top of all of that anatomy, we also have our eye movements. So why do we move our eyes around? I think it's a really interesting question to think about. And the reason we have movements of our eyes at all is because we have a part of our eye that sees the best. And it's that macular region right over here and that dark spot. And right in the center of that dark spot is something called the fovea. So whenever we look at something, if someone knocks on my door right now and I make a look over there to see who it is, I need to do that because my peripheral vision isn't very good. When I need to really have something clear, I need to move my eyes to put that image on my fovea so that I can see it. So we can demonstrate here in a picture. If we look right in the center of the photograph with our eye, it's very clear. We can make out the details of the face, but what's actually happening when we look here is everything else is really cloudy off to the side in our peripheral retina. So if we wanted to see this whole picture clearly, we would have to move our eyes around the picture in order to see it. And double vision happens when the images are not landing on each fovea, on each spot in the back of the eye at the same time. So we look at something and it lands on the fovea in one eye, but if the other eye is misaligned somehow, it's too far out or too far in, it's gonna cause some double vision because that image is gonna land on a different spot in that eye. So here's a couple of the different ways that we move our eyes around. These fast eye movements called saccades might be used for looking in this I spy picture here to find something in a crowded visual environment. We also have kind of smooth following movements that we use to follow, such as a man walking down the street. In the picture above, we would use these smooth pursuit movements to follow him walking down the street. And what's really critical in Parkinson's disease is convergence. So when we read something, you can see here off to the left side of the screen that these circles represent moments when our eye stops to get a camera glimpse of the words. And then we use fast eye movements to jump and stop and jump and stop and jump and stop. And that's how we read. But our reading material is also right up in front of us, usually up close. And when we look at things up close to us, we have to converge our eyes or pull them in towards our nose so that we can still see a single image. So you can see that being tested in this individual here, young, healthy person. She's able to pull her thumb in, keep her eyes right on her thumb, and hold them there as long as she wants to. Perfect convergence. So let's move on to the second topic, which is what's been identified in research in Parkinson's disease with vision that may not be quite so clear what we do with that in the clinic at this point in time. One of those is retinal involvement. So we actually have the pathology, the abnormalities that occur in the brain in Parkinson's disease also occur in the retina. The retina is made up of neurons, brain cells, just like the brain is. So we have dopamine in the retina, and that dopamine is reduced in Parkinson's disease. And there's also alpha-synuclein, or the kind of classic pathology in Parkinson's disease that's been found in the retina as well. So in theory, having these abnormalities in the retina could impact someone's visual acuity, their ability to see on an eye chart, could impact their contrast vision, which we might test by using this disappearing chart to the bottom right to see how light of letters can a person detect, or it might impact color vision. The reality is that if I test someone on the eye chart or color vision or contrast vision in my clinic with Parkinson's disease, usually I find it to be pretty normal. So we have to use some pretty sophisticated tools like this very difficult top right color vision kind of matching and sequencing task in order to identify these abnormalities, not things we typically do in the clinic. And we really can't tell in a given individual whether there's dopamine reduction in the retina of a live person. In life, all we can do is maybe do some fancy electronic studies on the retina to try to get a sense whether it's normal or not, but this isn't something we typically do in the clinic. I will point out that it hasn't been fully explored what the impact of these retinal issues are on contrast sensitivity. And it's important to consider for safety purposes if an individual might have a contrast vision problem. So you can see someone's trying to step up onto a curve. We get some kind of 3D clues here from the lighting and the different shading of the curve. There seems to be an edge right here that we can see. But if someone has reduced contrast vision, it may kind of all have the same shadowing, and it might be more difficult to discern edges. There's tips that you can do to help with that if that's a problem. You can get some brightly colored tape and put it on the edges of stairs, for example, so that you increase the contrast. So moving back a little bit further to these pathways that I mentioned, the where and the what pathways, we can see that these kind of have secondary processing for vision. So by the time the vision reaches the back of our brain, we can perceive the image, but then the details about where it's located in the room or what color it is, that's all occurring in these what and where pathways. So if we have problems of the lower, the kind of what pathway, the patient might have difficulties recognizing familiar objects or faces. There might be some difficulties with recognizing words with reading, and there might be difficulties with color perception. If we have problems with the where pathway, these can be, again, things to be aware of for a safety standpoint, because there might be difficulties with judging distances or judging motion, or kind of navigating, figuring out where you are in the space within an environment, or misreaching for things. Now, fortunately, in the context of Parkinson's disease, these types of problems are quite rare in idiopathic Parkinson's disease. In Parkinson's with dementia, or Parkinson's or Lewy body dementia that has Parkinsonism also, different diagnoses, these can kind of coalesce into some problems that are quite common. One being something called ocular motor apraxia, where there's difficulties with moving the eyes when someone wants to move them, or something called simultanagnosia, which is difficulty seeing kind of the whole picture. So in this vegetable face picture here, someone with this might just see the vegetables and not be able to see that it makes up a face, and then the misreaching that I already mentioned. But so these are important to know about for caregivers, for patients to understand what's happening. But again, these are quite uncommon with idiopathic Parkinson's disease. If we look at eye movements in Parkinson's disease, there's not so much that's abnormal, except for convergence. The eye movements tend to be quite normal in Parkinson's disease, other than convergence. If we look really, really hard, sometimes maybe we can see a little something in a task such as this, where if an individual makes, he'll start to do it in a second, makes quick jumps of the eyes from side to side between two targets, at first he's going to do a really good job with it right here. He's going to jump, 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 and he does really well. But as he just keeps on going, the eyes just get a little tired and he can't complete the jumps all the way as well. That's really subtle stuff. Other than that, the eye movements tend to be normal in Parkinson's disease, aside from the convergence, which we'll come to in a moment. There have been studies looking at reading in Parkinson's disease. These little graphs up here show reading in somebody who does not have Parkinson's on the left and someone with Parkinson's on the right. And you can just automatically, looking at it, kind of see a difference in the black lines here. This would be the little eye jumps we make as we read across a page, and then we return, make a big jump to the next line. And so you can see in Parkinson's disease, there's kind of smaller and more movements to read a page. Similarly, one of the research techniques is looking at this test called mules. The what it means is here listed, but it's a test of objects, fruits, common objects, and it takes patients with Parkinson's disease as a group longer to do a task like this than patients without Parkinson's disease. But again, those are some of the things that we've paid attention to in the research arena. But what I think is really important for you today is what should the eye doctor be looking for with Parkinson's disease, and what can we really help with? So it's a common scenario in my clinic that the patient with Parkinson's disease comes in and they have visual symptoms and they tell me, I went to my eye doctor checked my glasses, said they were working, looked at my eye, said the eye is fine, said really everything looks pretty good. But the patient's still visually unhappy and still has some visual symptoms that haven't been addressed. So we see that quite a lot in neuro-ophthalmology. And one of the biggest reasons we see that is because not a lot of eye doctors, or not all eye doctors, I should say, really look for this issue of convergence insufficiency. So again, we see our nice normal convergence here in this video that we saw earlier. So what happens in Parkinson's? What happens in Parkinson's is a weakness of convergence. So like I said earlier, convergence is critical for seeing a single image when we look at something up close to us. And we really should be able to do it up to about 5 centimeters of our eyes. But with Parkinson's, it's sometimes way out in the distance and no more convergence can happen. So here's an example of a mild problem with convergence. So she's able to bring the eyes in, but at some point, they just can't go in anymore. And one eye even starts to turn out to the side a little bit. So that's some weakness of convergence that's kind of mild to moderate. If we look at someone who has more severely affected convergence, he's looking at this pen being drawn in towards his nose, and we really don't see any eye movements at all happening there. There's no convergence or very minimal convergence happening. So that really, when the eyes can't converge, that leads to very poor visual quality in a lot of patients. When I know that it's truly symptomatic, it's really bothering that patient, is when they tell me, I see two side-by-side images every time I try to read something. I know that's from convergence insufficiency, but sometimes it's not that obvious. Sometimes the patient just reports some blurriness with reading, or that they can't read for a long period of time. They can read for 5 minutes and then everything gets blurry and they can't read after that. So it's always worth looking for this carefully in Parkinson's disease. And it also doesn't really respond to dopamine. So the Sinemet, the medications for Parkinson's disease there's no on-off with convergence, and it doesn't tend to help it out very much. So what we do to treat it most often is prism glasses. We take the work out of the eyes and put the work in the glasses. So there are exercises that can be done. We call them pencil push-ups. You take a pencil and draw it in, and you just kind of practice exercising those convergence movements. But most of the time in Parkinson's disease, it's really going to be best treated by prism glasses. Now, this is the only example I could find online, but it's a terrible example because the glasses don't really look like this. Sometimes you can hardly even tell that the prisms are present in the glasses. They can be ground into the glass, or we can trial little stickers on the reading glasses you already have to see if the size is right for treating the convergence problem. Now, I like to point out, this is not a one and done kind of deal. So the eye doctor, me, the neuro-ophthalmologist, whoever it is that's doing this treatment has to start somewhere. So we're going to pick a size of prism, put it on your glasses, let you go home, see how it works. If the problem is still there, it doesn't mean that prisms can't work for you. It just means that maybe the size isn't big enough. So it's more about a relationship back and forth with the doctor until you get it right. So the last thing here is simple solutions and take-home points. So I already gave you one of those, and that is really kind of working with the doctor on different prism trials, different pairs of glasses to see what can work for you. Sometimes patients with Parkinson's disease don't tolerate bifocal or progressive lenses well. Sometimes patients tolerate them great. Sometimes the prisms are put into progressive lenses, and that works great for the patient. But for various reasons, if a patient with Parkinson's disease is visually unhappy, one of the first things to try is to get them out of bifocals or progressives and into single lens glasses. So glasses for the task. It might seem a hassle to have 2 or even 3 pairs of glasses, but if that's what it takes to get the vision just right for each activity, patients usually find that very rewarding in the end and don't mind switching glasses. So they might have 1 pair of glasses with prisms in it that are for reading, when 1 pair with a smaller prism for the computer, and then a pair for walking around on the street or usual daily activities that have no prism in it. So It takes someone really working with you and listening carefully to you to hear what your goals are, what you want to do, and where specifically you're running up against obstacles in doing that. Another thing that's really common with Parkinson's disease is dry eyes. Now, patients with Parkinson's, just like the movements are affected in the body, the movements of the eyelids are also affected. So patients with Parkinson's disease don't usually blink as often as patients who don't have Parkinson's disease. And by default, the eyes then tend to get dry because when we blink, we lubricate our eyes. So this can be very non-obvious. So I always ask patients, do you have a sandy or gritty feeling in your eyes? And that's an indicator of dry eyes, but most often they say no. I'll also ask them, do your eyes tear a lot? Do they run water? Excess tearing of the eyes is a little bit non-intuitive, but it's a sign that the eyes are dry. And the last way that I know if someone's eyes are really dry and it's impacting their vision, time and again, I'll have patients in my clinic who sit in the chair, we're testing their vision on the eye chart, and I have them try to read a line, and then they have some struggles with it, and they can't get so far to the bottom on the eye chart, but I have them close their eyes or blink, 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 and time and again, I'll see improvements of 2 or even 3 lines on the eye chart just from blinking the eyes. So it's not to be dismissed, this issue of dry eye and Parkinson's disease. So I tell patients to get lots of bottles of natural teardrops, put them around the home, and just use them liberally. No medicine, can't hurt yourself by putting in natural tears though. I'll also point out this little vial over here in the picture. So you can buy plenty of bottles of natural tears. All the ones that come in a bottle, they have some preservatives in there. Many people tolerate them fine, but if those are irritating to the eyes, you get these little vials of tears for single use. These are called preservative-free tears, come in a box, and those will take away the irritation. And I'll also point out many patients with Parkinson's get sent to see me, but they haven't seen an eye doctor in a long time. And some neuro-ophthalmologists are ophthalmology trained, and some of us, like myself, are not. So we deal with brain vision, and every patient, really, I advocate for every patient over the age of 60, even if there's no neurological illness, to see a regular eye doctor, because at that point we want to really proactively screen preventative health. We want to screen for glaucoma, have that eye doctor screen for cataracts as seen in the picture down below here, and just to make sure that all the glasses are updated and working well. So back to the scope of the issue, to give just a little summary and a little more detail. 78% of patients with Parkinson's disease report at least one visual symptom. If that visual symptom is blurred vision, that's pretty non-specific. It might not be related to the Parkinson's. It could be that an update in glasses is needed. Maybe there's cataracts. Maybe there's something else going on with the retina or the eye. In part from Parkinson's specifically, it would be more the dry eye issues. It gets better with blinking or lubrication, or if it's specifically for up close, it might be that convergence problem. Difficulty reading, if it's not from Parkinson's, maybe the patient just needs stronger reading glasses. We will, as we get older, need stronger and stronger reading glasses. And if it's from Parkinson's, it might be either the dry eye or the convergence problem. Double vision is a tricky one because I talked about double vision from eye misalignments, and that is true with convergence. The eyes aren't playing as a team so that there's double vision, but double vision can also occur with just one eye open. So if I have double vision right now with just my right eye open, that's not from a team problem, not from an eye movement problem. That's something going on here. Maybe it's dry eye, maybe it's my glasses need updating. So double can be a little bit tricky to sort out. And lastly, the light sensitivity. which can be from dry eyes. Dry eyes are always light sensitive. And then there's this issue called Blepharous spasm, where the eyes are kind of blinking. If you bring your hand towards the eye, there's excess blinking, and along hand in hand with these types of spasms of the eyelids comes light sensitivity usually. So I'm often asked, who should I see first? An optometrist, which is not an MD, it's an OD, optometry doctor, an ophthalmologist, who's an MD, or a neuro-ophthalmologist. I would advocate to always start, if you have Parkinson's disease and you're having visual issues, really start with an ophthalmologist. You want a good checkup of the back of the eye, good glasses update, good checkup of the surface of the eye, and the ophthalmologist is generally going to know. If they don't figure out the problem, they may recommend for you to see a neuro-ophthalmologist. On the other hand, whoever you see first, if you're still not satisfied and you're still having a visual problem, don't stop. Keep seeing other doctors. Try the neuro-ophthalmologist. Try someone else until you find the person who can help you. So final take-home points from the slides. One size does not fit all. Every patient with Parkinson's is different, has different needs for glasses. You really want a doctor who's listening to you. That's half the battle. What are you struggling with, and what can we try to make it better? And sometimes the very simple things, treating those dry eyes, keeping the lots of bottles of teardrops around, can really make a tremendous difference. So I think that's all I've got in my slides. I'd like to thank you for listening to me for this portion of it, and thank you for your attention. And I think I'll stop sharing now and we can have a discussion.
That was so clear, Janet, and you're so thorough. I literally wrote down a bunch of questions while you're going through, and you answered a lot of them while we were going through. So yeah. I think that was. Well, we also we often read each other's minds, so it's kind of fun. So I think one of the questions that comes up is, so should people be proactive as soon as they get Parkinson's disease as a diagnosis? Should they be trying to see a doctor, or should they wait for symptoms to happen before they see a doctor?
So I would say, with regards to the diagnosis of Parkinson's disease, not necessarily. No need to be proactive about checking vision. Wait until you have visual symptoms, because if you're not having visual symptoms, even if you have convergence weakness, but you're absolutely happy with everything about your vision, that convergence weakness doesn't need treatment. And I should also point out that the convergence problem it's not been well studied longitudinally, meaning if an individual gets convergence weakness, is it just going to keep getting worse over the years? I really don't think so, because once we address this with prism glasses, usually patients are set for a good long while. They're not coming back to me saying they're not working anymore. Okay. But the flip side of your question, I'll just turn it around to repeat something I said earlier, which is, regardless of Parkinson's disease. So this is not proactivity for Parkinson's disease, but I really advocate for any patient over 60 to be seeing an ophthalmologist annually, just for good preventative eye care. Like, we get our colonoscopies, we get our mammograms, we get our cholesterol checked. I think good eye care is part of that preventative regimen.
That makes a lot of sense. So just kind of incorporating, we can't take all these questions from the chat because there are a lot, but one question is about the pencil push-ups that you mentioned. Do they actually help?
Well, so the first thing I'll say is they certainly don't hurt. So why not try them, right? They haven't been studied very well, actually, in Parkinson's disease. So convergence insufficiency is also quite common in children, but they outgrow it. But because it has implications with regards to schoolwork, it's been really rigorously studied. So there can be home vision therapy, which is the pencil push-ups, or in-office vision therapy through occupational therapy or maybe optometrists. And in kids with convergence problems, office has been shown to be superior to home, but we usually start with home, because if it works, great, and it's free. So in Parkinson's disease, it hasn't been very well studied. I will say my routine If someone with Parkinson's is symptomatic of convergence insufficiency, I'm generally going to recommend they get into prism reading glasses, but occasionally that convergence deficit is mild, and I can tell that on the exam. Then in that setting, exercises may really help.
Okay, that makes sense. There's a few questions about the eye dryness issues. So if somebody is needing those, and I think they linked the drops that you had mentioned, a lot of eye drops during the day. Is there a need to put any lubricant in at night? I know sometimes people use, Vaseline kind of gel type things. And there's also been a question about if people's eyelids stick together at night and are difficult to open, is that, something that they should be sort of thinking about?
Yeah, so let me answer the second part first. So let me preface also by bear in mind that I am a neurologist. I am not an ophthalmologist. I'm not an eye doctor. So anything you hear from me is just based on me seeing patients in clinic. I'm not the end authority on these issues. But the second part of the question, if my eyes are kind of stuck together in the morning, that's a common problem. That usually isn't so much due from dryness because typically our eyes are closed overnight unless we have, in Parkinson's, they should be closed overnight unless we've had like a Bell's palsy, a facial weakness or something where the eyes can't close. So that's usually due to something called blepharitis, which is also really, really common, where we have inflammation in the glands at the base of our eyelids. And the eye doctors have ways to treat that. The first thing they usually recommend is just warm compresses. So like a hot washcloth, and you just hold it on for a few minutes each day, sometimes can clear up those glands. But if that's a problem, waking up with matted eyes, sleep in the eyes stuck together, crusted, you should see an eye doctor to get some help for that. It's not a dangerous problem, but it's not comfortable. Back to the first question, the same thing really holds true for dry eyes. So as a neurology trained person, I know that these dry eyes are common in Parkinson's, and what I recommend is just the natural tears. However, if that doesn't help, or if the patient really is substantially bothered by dry eyes, always worth a visit to the regular eye doctor, or even more particularly, a cornea specialist, a surface of the eye specialist, a cornea doctor, because there are many more treatments for dry eyes. There's prescription medicines. If they're really bad, they can put little plugs in the tear ducts to treat it. So there's other treatments available. So always consider seeing the right specialist for that.
Okay, that sounds good. There's a question about a patient who has a dual diagnosis of MS, maybe 10 years before they ever got Parkinson's. Do you see many patients with the two diagnoses together?
No, but that doesn't mean that it can't occur.
Yeah, I would agree with that too. We don't see a lot, but it can. There are things that may occur. Another question is about those tinting sunglasses, the ones that auto tint. Do you recommend them or not? Or glasses that have the tinting that as soon as you go out or in, is there any recommendation one way or the other from your thought process on Parkinson's patients having those?
Yeah, so again, I preface with I'm the neurologist, so I'm not the expert here, but I think that the reason those tinting glasses, like if these glasses turn dark when I go outside, I think the reason they really exist is to protect the retina, because sun exposure, lots of sun exposure in our lifetime, I think is linked to macular degeneration. And so that's not at all related to Parkinson's disease, but that's why it's good for all of us to wear the right kind of sunglasses with UV protection in them. But with Parkinson's specifically, there's no specific reason to wear tinted lenses unless someone's dry eyes or those kind of eyelid spasms that I mentioned were causing a lot of light sensitivity. Then you wear whatever's comfortable for you. That's how you treat yourself there, is by trying different tints, blue tints, rose tints, find something that helps to minimize that discomfort from the light sensitivity.
Okay, that answered one of the other question.
Me, I don't think that whether or not to take out cataracts would be dependent on the Parkinson's. I think it would just depend on whether or not the eye doctor felt that the cataracts were visually significant, that they were causing problems.
So there's been a question or two about COVID and the safety of going into an ophthalmology office or optometry office currently with, what your sense is. And maybe you could speak a little bit about how you've been modifying. I know I saw a paper that you just wrote, Janet, about, being able to take many of the aspects of this complex eye exam and do it over, Zoom. So maybe you could speak a little bit about, what your perceived risks are. And you practice in New York, which, it's been, I know you've had a lot of patients, and you've been right in Manhattan with a lot of the outbreak initially. So maybe you could speak a little bit to that.
It's a really interesting question because there are so many facets to it. I think anything I say, you have to bear in mind it's regional, because the risk of going into anywhere depends on what the rate of infection is in your place right now, right? So right now in California, there's more cases than in New York. In, mid-April, there were more cases anywhere than there were in New York City, right? So it kind of depends on where you are. But I think that doctors are communicating nationally in academia, in academic medical centers about these issues and sharing tips and what we're doing and figuring it out. What we did was essentially when very quickly after cases started rising here in New York City, Governor Cuomo basically shut down the state very fast. And in our offices, in all of NYU, we all stopped seeing outpatients. And that posed a big problem for our patients. And we would still see emergency patients, but we transitioned nearly 100% to telehealth care. And our specialty of neuro-ophthalmology and ophthalmology has a lot of challenges in telehealth because a lot of the testing that we do is dependent on the office, in the office, right? We need our machines, we need to look in the back of the eye. There's really no way around the back of the eye. We simply can't see it over tele. If we need to see back there and see what's going on, we have to bring someone into the office. But we were able to accomplish quite a lot with the eye movement exam. For example, I saw some patients, new patients with Parkinson's disease by tele in April and May, was able to diagnose convergence problems, was able to, talk about the dry eye issues. And we've made a lot of progress. We can pretty much do everything except look in the back of the eye by tele.
That's amazing. And you're sharing that information as well, which is great. There's a question about if you have any suggestions for putting in eye drops, because it sounds like people are, because of the dryness, are trying to do that. But, there has been presumably some folks that either due to motor issues, are having issues. And I know it's hard anyways. I've had to, learn how to do that myself.
For some people, it's just going to be a no-go no matter what you do, because some people just cannot tolerate anything near their eyes. They clamp them down, squeeze them shut, and you can't pry them open. So then you just sort of put it there and hope something makes its way in when they open them. But it's probably with Parkinson's disease, it's probably most of the time easier if there is a caregiver. And the best way to do it is to have the patient kind of lay down or recline on the chair, pull the lower lid down, person looks up, and you just slip in a drop. Sometimes they have to, use both fingers and really pry the eye open to get it in, but the patient needs to be back. If the patient's like this, you're never going to get them in, okay? For the patient for an individual to put them in themselves, there's no great trick to it. It's sort of like some people can put in contacts and some people can't. You just have to put your head back and do your best. Aim and squeeze and hope something gets in there. There's no magic.
Okay, that sounds good too. Question about the Blepharous spasm. So in some cases, you mentioned that with Parkinson's, you can actually get the eyes forcefully close, and then sometimes as the disease progresses, we also see that there's an issue where people can't actually open the eye, which is what we call apraxia of eye opening. Do you have any sense of how to approach those, and you know, when you might see them and how you might differentiate them? We have about 4 minutes left, so maybe this will be our last question.
Yeah, so those can really be problematic issues. I've seen patients with this thing called lid opening apraxia. Basically what it looks like in the exam, we tell the patient to close their eyes, they close their eyes, and then we say, now open your eyes, and nothing happens. And you can see their eyebrows going up, their forehead wrinkling. They're trying to open and they want to open, but the eyes just won't open. And that can be bad enough that patients are actually kind of legally blind from it. If they can't open their eyes, they cannot see. And these issues, the first line of treatment, hands down, no question about it, is Botox injections. And usually, most of the movement disorders doctors do them, or they have someone in their practice who does them. If not, then a lot of the ophthalmologists do them as well, or neuro-ophthalmologists. Can be
So just to
really
clarify that, so we sometimes use injections, which are botulinum toxin. So this is something like we use with wrinkles in some people, that the people know more sort of out in the universe of lay public. But we do use these sort of toxins to help with what we call dystonia in other body parts. And you guys use them a lot in weakness of eye muscles and pulling of eye muscles and things. And so we can actually use this, but it does take you know, a special type of doctor to do this, who is trained in either movement disorders, or I would say a neuro-ophthalmologist or an ophthalmologist. You don't want to be going to a plastic surgeon or somebody else who does these cosmetically. You want to look for the right doctor who can look and see what the issue is and then treat the problem. And then it's important to report, you know, back as to how it went. Sometimes a side effect of this can actually be double vision or other issues with vision, sometimes because of weakening but it usually is well tolerated, I think. So I think it is an option. So again, something to be really, you know, telling your doctors about, because it might not show up when you go into the office. And so I think, you know, being able to convey that, and like Janet said, it can be really sometimes disabling if it happens, you know, for a period of time. People can't really see, and then it can affect how they're moving and how their balance is if it happens when they're trying to walk and things. So really important. So so I think this hour has literally gone by, Janet. It's been so rich, and your slides were so clear, and I think we all learned a lot. And we'll make this, people have been asking if they can get a copy of the video and stuff, and we'll make that available, and some of the links and any other resources that you might have, you know, please let us know. And so, yeah, maybe I'll give you a last goodbye opportunity, and maybe some hope to inspire us, since you guys have been very good at, you know, reducing the number of cases in New York. Maybe you can give us hope in the rest of the U.S. and say goodbye to us, and
there's always hope, right? We have to stay positive. We have to think positive. There's always hope. This will pass at some point. We're not going to be living with COVID forever. It will pass. There will be a vaccine one day, and we will return to being able to engage directly with one another. It was really fun being with you today. I'm grateful, Indu, for the opportunity and for your friendship and everything. So thanks, everyone. Everyone stay safe. Take care out there.
Thanks so much, Janet, for taking the time. I know you're extremely busy and running around covering all these services. So we really appreciate I appreciate your friendship, and it's just been lovely. And I can't wait to see you again and travel somewhere exotic with you again, and continue to go to our meetings.
So we can travel again. Yeah.
Scott,
Take care out there.
Andrea, back to you.
Thank you to both of you. This was such rich content. I know I'll be watching it again when it goes on our YouTube channel. That should be up by the end of the day today. So thank you, Dr. Subramanian. Thank you, Dr. Rucker. And we always show our thanks with a goodbye wave. So I invite you to turn on your camera, put it on gallery view, and you can scroll through and see the boxes of everyone's big smiles and big waves. Thanks, everyone.
Thank you. Take care, guys.
Thank you.